And how do we treat this uveal melanoma when it's diagnosed by the ocular oncologist? So before we advanced quite a lot in knowledge about this disease, and now what the way we treat, the way is standard of care across most practice is that the way we treat these patients that we want to do strategies that spare the eye. So before ages ago, well, the standard of care was to do an enucleation and a removal of the eye. But nowadays, most cases are adequately treated with radiation, various types of radiation, laser treatment, and a very selected cases where the physician will prefer to do a surgical approach. The important as well is that with this eye sparing treatment, we can provide a very good, adequate control of primary eye cancer, meaning here of primary uveal melanoma. More than 90% of the times, this treatment will be effective. And how do we do the follow-up once we diagnose this patient with uveal melanoma and we treat this patient, and how do we follow those patients? How do we prognosticate? How do you predict the risk of this cancer to recur? So what we do is that there are different ways to prognosticate this patient. There is not a standard practice given the rarity of this disease, but the most common way is that we do the size of the tumor. So we measure the depth of this melanoma, and this will prognosticate according to the size. We will stratify these patients between low, moderate, or high risk of recurrence. Another important aspect of the prognostication is that the molecular assessment is very important. The only thing that I should mention is that when you are measuring the size of this primary tumor, you don't need to biopsy. You don't need to do a fine needle sampling. You can do this using an ultrasound and various techniques from ocular oncologists. However, for once a patient has a biopsy and he undergo tissue sampling, you can definitely assess the molecular aspects of this tumor in different ways as well. You can analyze the cytogenetics, or you can analyze the DNA mutations. So this will provide to the patient also an important assessment for when you are risk refining these patients, and that will be important when you are planning surveillance moving forward once this tumor is treated. And how is surveillance done? Overall, there are no standard of care practice. However, what we do have in mind, and the patient needs to have in mind, is that he needs to undergo some sort of imaging moving forward. Our practice here in Toronto, in Canada, is that we do liver MRIs for these patients, and also some sort of chest imaging, and this can vary a bit according to the risk of recurrence once this patient is prognosticated based on the size, or based also in the size plus molecular assessment. So this is very important, but the key message here is that once these patients are treated, given the high risk of recurrence, going up, reaching up to 50% in more than 15 years, these patients will need to undergo some sort of imaging for surveillance. And once they are high risk, what we advocate is that for lifelong imaging to make sure that we are able to track a recurrence in the early stage and treat these patients, trying to aim for a cure and improve prognosis.